So I'm going to take a moment now and introduce our guest speaker for the evening. This is Kathleen Nightingale. And I can't help but think of Florence Nightingale, the nurse, every time I see your name. I'm sorry. But Kathleen has an incredibly interesting topic to talk about tonight, and it's Alzheimer's. And I believe her husband, Dan, is here.
Uh-huh.
Where is he?
He's hiding.
Dan?
You have to find him.
Disappear? I wasn't one of them.
Yes, you did. I think it was Mike who did it.
Oh, you're there. There you are.
I'll
Okay.
go up to being done.
So I believe you've done a lot of the work and research that Kathleen's going to present.
That's right.
So we have a presenter and we have an expert, a second person of information about all sorts of things about Alzheimer's. And really fascinating because very few people have really studied it and shown results with this. And when I talked to Kathleen over the phone, she said that it's very, because I wanted her to bring somebody up here, you can work with me, because I probably have Alzheimer's, right? So I wanted her to actually work with somebody to demonstrate the technique, but we really she needs to set it up and know a little bit more and to have an adequate subject to work with. So I felt, she's not going to be able to do a formal hypnosis with anybody to demonstrate, but she'll go through in her presentation the types of things that they might be doing. So without any further ado, Kathleen, it's all yours.
Thank you. How is everybody? Are we all awake this evening?
More awake than I was.
Here's a suggestion. You will love this presentation. I'll just cover a little bit tonight about who am I. Oops, did I move that off this? There we are. The work, how I got into this work in the first place. About Dr. Dan's study, and why you need to know more about working with this segment of the population. So let's get started. I should mention that I studied with Linda Bennett at SWIHA, and I understand Linda was here last month, and which was very interesting. I studied mind-body wellness, got my clinical certification through SWIHA. I actually had a business and finance background, but really wanted to help people in a much different way, and just love the whole thought of mind-body wellness. And I'm not exactly a great body worker, but I love working with the mind. And so that was several years ago that I attended SWIHA and studied mind-body wellness. And in about 2011, in about the spring, I think it was, I relocated to Prescott, getting out of that heat down here after 22 years. Stick a fork in me. I thought, well, it'd be nice to go to the Mile High City up there. So I opened an office and started thinking to myself, there's a huge population of elderly people up here. There's a lot of retirees, people who've moved over from California. It's not exactly a place where people go to work normally. It's usually where they go to retire. So I started thinking about how can I really help this group up here and really kind of target something that they may need. And part of that was, I don't know if you've ever heard of Highgate Senior Living. There's a lot of course, nursing homes and assisted living places in the state, with Arizona being one of the top states for elderly. And Highgate was saying, we love doing holistic things with our patients here to help them relieve their anxiety, and we love to do things like aromatherapy and massage. And I went to the executive director over there and I said, have you ever thought about hypnotherapy? And as usual, what's hypnotherapy, right? So, I got to wondering about that myself, and I started researching online, and every time I kept Googling it, searching for information, the study was coming up, and Dr. Daniel Nightingale's name kept popping up everywhere. It seems to be the person who really worked on this for years and had more knowledge than anyone else out there I could find. So I thought, I wonder if he's got any training going on. He was over in England. Is he coming to the U.S. at all? So I I sent him an email. And as he said, he was in his rounds at a nursing home. He was actually at one point managing over 800 nursing homes. And he was a dementia specialist and a consultant on how to improve the environment of nursing homes, how to improve the overall quality of life over there in the UK. Was all over England, Wales, Scotland, Northern Ireland. And about the same time that I contacted him, this woman named Maria Boylan, who was she had been a neuroscientist at UCLA. She'd been working with the chemicals that were developing the drugs for Alzheimer's and dementia, well, Alzheimer's specifically. And she had some adverse reaction to those drugs, those chemicals, I should say. And she was looking for ways to, how can I work with these people? How can we help them without drugs? You probably know there's Aricept and some others out there. Don't really usually help very much. In fact, there is a Dr. Gandhi who's from Mount Sinai in New York who did some research not long ago that showed that these drugs that are supposedly preventing these plaques and tangles that cause Alzheimer's disease or are part of Alzheimer's disease are probably actually killing the army that's fighting the disease. So it may actually be making it worse. But, we love prescribing drugs in this country, right? And believing that that pill's going to fix everything. We all know here that it generally doesn't. So Mario was emailing him, I was emailing him, and he put us in touch with each other and was hoping we'd both just kind of go away. Just go away, I'm in England, leave me alone. And we put our heads together and we said, well, maybe we could bring him over here, or should we go over there? We ended up bringing him over here and did a training with him. So we got to pick his brain and learn his techniques and everything he had developed on working with dementia. So, and from there we developed the workshop on hypnotherapy for Alzheimer's and dementias. And we've been facilitating the workshop in the UK, Canada, the US, predominantly in the UK and Canada, actually. There seems to be more interest outside the country, surprisingly. But I think in other countries, the UK, what's interesting, of course, they have their national health care. What happens is because the government has to spend so much money on, they have to pay for medication, they start going, well, what alternative ways can we help people and work with people without having to spend a bunch of money on medication? So in some ways, that's a good thing. If somebody has irritable bowel syndrome, the doctor will prescribe hypnotherapy. So a lot of times, hypnotherapy is used as a first-line treatment before drugs. So that's why, it's just often used over there, and there's a lot of interest in it over there and training that we've done. We facilitated a workshop in London back in May, and then we developed a distance learning program. So through the distance learning program, we now have dementia therapy specialists in England, Scotland, Wales, Ireland, Canada, China, Australia, Italy, the Netherlands, South Africa, and the US. So it's growing. We get contacted by people from all over the world saying, we're interested in this training. So prior to this study that Dr. Dan worked on, in the UK, the National Service Framework for Older People through the Department of Health presented 8 standards of health care provision, including person-centered care. Dr. Dan could probably explain that in more detail, but with regards to dementia, this approach endorses the importance of enabling an individual to fulfill their potential and remain a social being despite declining capabilities. So person-centered care is what it's all about. There was previous experimental evidence that demonstrated the use of hypnosis for producing, positive behavioral change and reductions in medication in people living with dementia. This was prior to the study being started, of course. And Dr. Dan and his colleague, based on their understanding of the literature, they found themselves in the position where the person living with dementia's personal environment impacts upon their clinical presentation. So the environment, I'll get into this more, but there's a lot more to dementia than memory loss. They're affected by colors and environment, and there's a lot to know about it in working with this segment of the population. Hypnosis appears to be able to impact upon individuals. Again, this is prior to the study, both those living with dementia and others through their personal environment and their experience of quality of life. So why did they do the study? Well, Dr. Nightingale was already a clinical dementia specialist studying hypnotherapy at the time, and he needed to do some primary research, moving away from pharmacology and how could they move away from pharmacology and dementia. And at the time, he met Dr. Simon Duff, who I guess asked him to make him a cup of tea in the lunchroom or something, and next thing they became best friends. And Dr. Simon Duff was working with the University of Liverpool at the time. So they decided to get together and do the study. Even there were some negative attitudes that said, well, that won't work, as people with dementia are already in a constant state of altered conscious awareness. And they said, what? It was just, even with people who are working in hypnotherapy, just wondering, I know it's a disease of the brain, how can this work? Are they really in an altered state of conscious awareness? Not really. So Dr. Nightingale and Dr. Duff ask themselves, can hypnosis play a positive role in the quality of life of people living with dementia? And does this impact upon clinical presentation? And can we show this impact? So they embarked on this study and found I guess it was the owner or the CEO of a nursing home, a group of nursing homes who actually agreed to help fund the study, which was nice of him. So it was conducted by Dr. Nightingale and Dr. Duff in conjunction with the University of Liverpool. There were 2 care homes involved in this study, and that's where the therapy was conducted. And the participants all had moderate or moderately severe cognitive decline. And there's ways that we teach people how to do assessments in that area. Hypnosis sessions were conducted weekly over a 9-month period at the nursing homes. And a full year after the sessions were completed, there was a longitudinal study to see, how are they doing a year later after all of the therapy was completed. So in the study, there was 3 groups. There was the therapy group, which was the hypnosis group, the control group, which had weekly topical discussions, and then a neutral group, which was treatment as usual. I'm just reminded of something as I talk about the study. What I found interesting about Dr. Dan at the time was that he was working, background by the way, RN, social worker, and then PhD, and he was working in as he said, the sexy field of forensic psychology and working with offenders, and he was enjoying that work, and his boss said, you're going to go work with dementia people. And he said, oh. In the beginning, I don't think so. I don't want to go work with dementia. And I'm kind of backtracking here, but then he was told months later, yes, you will go work with dementia. And I just want to add that he talks about going into the nursing home and seeing the state of things, and this is however 15 or so years ago, I think, and they were in these chairs where they couldn't get out of the chair. They were like tipped back, or they had these things in front of them, and it's like, oh, don't let them wander, they might hurt themselves, and let's just give them an antipsychotic drug, which really isn't licensed to be used with dementia, and it can be deadly. And he just saw the state of things and said, you know, something really needs to change. And that's where he became really compassionate about working with this group of people, and also became involved in something called Always a Last Resort, which you can Google. And it was an all-party parliamentary group in the UK where they said, you know, in fact, people were dying from the use of antipsychotics. And it's now a policy in the UK that antipsychotics are only to be used as a last resort. So that became a policy through the work that he was doing along with some others. And I just want to segue and mention my mother, my own mother had dementia, vascular dementia, and just passed away in December. And found out that she was in a care home she was in for a couple of months this fall. They were overdoing it, and they were giving her an antipsychotic that was supposed to be only as needed. Again, it's, you know, we don't know how to deal with this. They're anxious. Let's slip them an antipsychotic pill. Come to find out, she had a urinary tract infection, which was exacerbating her behavior, making her even more anxious. But instead of realizing what the problem was, let's just give another pill, which I think actually, ironically, may have contributed to her death. So, yeah. So there's some actually investigating going on there. So I actually became part of the whole problem, or not me personally, but you know, my family witnessed firsthand what's still going on in this country with antipsychotics that they've been working so hard to get away from in the UK. I think here in this country, for something like every penny spent on, or dollar spent on cancer, there's a penny spent on dementia and Alzheimer's. So definitely a neglected area that we need to work on. So anyway, I just want to get back to some of that background prior to the study and why it was so important to find another way of helping people. And hypnosis was another way. In the study, they looked at 7 measures, or 7 areas of quality of life: concentration, relaxation, motivation, activities of daily living, immediate memory, for significant events, which is long-term, and socialization. And it was measured weekly over 9 months, and then, of course, 12 months later after therapy was completed. So I'll show you some interesting graphs here. You'll see the hypnosis group at the top. The discussion group is here. Treatment as usual down here. So, and at 9 months, that's where the therapy stopped. So they came back into the longitudinal study a year later, and there was still improvement in the hypnosis group in the area of concentration a year later. Activities of daily living and how they can, you know, feeding, clothing themselves, whatever. Again, we've got the hypnosis group up here, still improving a year later, and the other 2 groups down at the bottom. Motivation really jumped up in the first 3 months, and then, you know, declined a little, but still compared to the other groups, the motivation of the treatment as usual, way down low. Socialization. Again, there's so many different aspects of how dementia affects an individual besides memory. Loss of, you know, when they find they've got dementia, it's self-esteem goes down. Well, what if I forget my friend's name or forget how to get home? Well, I guess I'll just stay home and not go anywhere. So their self-esteem goes down. The anxiety increases as they're worried about what they're forgetting. Fueling this dementia and using up cognitive abilities, and it just snowballs. So through the hypnosis, socialization actually improved, self-esteem improved, and then we have the other two groups, down there again. Immediate memory, which is the first thing really to be affected, long-term memory. If you know anybody who's had dementia, immediate memory is normally affected first. So it improved, and then a year later, even more improvements. And then here's the long-term memory. Again, up there at the top. The other groups are at the bottom. Relaxation, that's the only one that really kind of declined. You know, I think after the hypnosis was stopped, maybe the level of relaxation just declined because the therapy wasn't continuing. But if you look at the mean change in overall quality of life, that's everything combined, how positive the impact was. And I think they were surprised at the results. They didn't know what to expect really. People didn't know who was involved. The caregivers, the nurses didn't know who was involved in the study. So, due to the greater difference in quality of life for the hypnosis group than changes in the quality of life of the other two groups did not really differ statistically, as you can see. Yes.
Question.
Yes. Yes.
On the treatment as usual, every single one of those, there was an increase, a marked increase, albeit quality of life was still rated at 0, crap. But there was a definite increase between 9 months and 21 months.
Mm-hmm.
Was that because that treatment as usual was then altered after 9 months? Or was that treatment as usual continued between months 9 and 21? So there was a difference, and that spike went up.
Yeah, but treatment as usual after the 9 months, the treatment as usual group will then start being treated differently.
Okay.
So if they needed medication for whatever problem that they might be having at that time, they would have medication. With it being a neurodegenerative disease, then they would be deteriorating. So they would be getting different treatments. For the 9-month period, we all agreed, the medical team agreed, that nothing would change unless there was a serious problem with the treatment as usual group.
I have 4 questions. Who performed the hypnosis? Were there scripts involved?
Right.
How many subjects were there? And then the last one, trying to address the statistical significance of the studies.
Okay. Do you want to answer those questions? You want me to do this?
I believe was there 6 in each?
Yeah, we had. What was the first question?
So many
Who
people.
performed hypnosis?
I did the hypnosis, right. We
did
worked.
so
yeah.
that's a constant?
There was myself and Duff. I did the clinical work, and he's the more academic, so he did the scientific data and the analysis. So
Did you use a script, or did you just, how did you do it?
we had a particular script for each individual, but it was basically 2 scripts. One script was a forest scene, and another script was the beach.
Okay. And can you elaborate a little? Do you have examples of the scripts?
Yeah, I mean, it's in the publications, the journals that published it, there's some information about the script, but it was basically, I was taking people into a forest, and I was guided visual imagery. Really surprising to me that guided visual imagery for people living with all kinds of dementia, and there's over 100 types of dementia, guided visual imagery is fantastic to work with each person with dementia. Really surprised. The things that we found in this study that kind of surprised me, but guided visual imagery.
So that was the kind of thing that you did?
That
was the main. How many subjects did you actually work with?
We had 6 in each group, so there was 6 active treatment, there was 6 treatment as usual, 6 in the control.
So it's a small number.
It had to be a small number because of the kind of group of people that we're working with.
You're looking at like moderately
Because of mortality rates.
And with that number, can you actually draw statistical significance?
I think so, yeah. I think we've been able to, and especially that was proven to us with the longitudinal study. You know, the fact that we didn't even think about doing a longitudinal study. It wasn't even part of our plan.
And you mentioned a publication. If someone wanted to read the publication,
Yeah, it was first publication was in 2005 in the European Journal of Clinical Hypnosis. The longitudinal study was in the same journal in 2006, and then the Alzheimer's
Care Today in the
they are here,
U.S.
so you can show them.
Well, I don't have copies.
Okay.
Can
Oh, wait a
you find
minute.
that online?
Actually,
Can you find that?
Probably, yeah, absolutely. So yeah, what was there another question?
You got them all.
I've got them all.
Yeah, you covered them all. Thank you very much.
Okay.
I have a question. When you were doing the guided imagery, did you give suggestions about their memory when you were doing that?
There's a journal.
Each of the 6 people, each of the 6 active participants had different challenges, ranging from inability to remember. So if I was to give, what's your name?
Karen.
If I gave Karen her clothes and said, we've taken these from the laundry, could you go hang them in your wardrobe? What do you call a wardrobe?
Closet.
Okay. Hang them in your closet. She would take them, walk a few steps, look at them. What am I doing? And put them down. Okay. So with that lady, I worked on her attention. Okay. And so with her, she was then able to do that. She was able to remember that she's taken these clothes and she would put them away. And it ranged through different challenges to another lady whose son was a surgeon at the local hospital. He used to come to see her 3 or 4 times a week, and every time she was concerned that he was going to be killed in a road traffic accident on his way to the home. We don't know why. There was no reason for this. So I worked with her. That was her issue. That was her challenge. And gradually that went away. That stopped. And she started looking forward to the visit from her son. And it was something that she prepared for, and she began to enjoy it. So they all had different things. So the suggestions that I was making was based on that particular challenge and that particular issue. And some of them did have short-term memory issues, immediate memory problems.
Thank you.
Sorry, Kathleen.
No, that's thank you. Thank you very much.
Take it over, Kathleen.
Thank you.
Okay, look, I'm not saying anything. In the longitudinal study, the hypnotic group were showing higher levels of quality of life at this time point, and the other groups did not differ statistically. So there were 2 component models of dementia, a biological component and a psychological component. Psychological component is anxiety and depression brought on by an awareness of changes in skills leading to ruminative thinking, as I was mentioning, getting depressed, getting anxious, which requires cognitive resources which are limited, and as such fewer are left for other kinds of cognitive work, such as attention, remembering, and socialization. There's some other great work that Dr. Dan has done, including with taking, by the way, Montessori, used with children, Montessori techniques for enhancing the dining experience. You know, we have a tendency to de-skill people. We think, oh, well, they can't do things anymore. Mom, don't do this anymore, or whatever. And then they actually stop doing things. But there's therapies that can actually help them to relearn, and it's, I don't know who coined the term, rementia instead of dementia, Tom Kitwood, bringing back, helping them to remember things that they'll never forget through space retrieval, helping them to relearn to feed themselves. So there's some really great work that's been done in it, if only we could get people to use it. Yeah.
The lady over there who mentioned the fact that if you believe that you've got ADD, you've got ADD. That's the same with dementia. You know, you tell people.
That's right.
It's a positive illusion, isn't it? There's a positive illusion. If you create a positive illusion, if I tell somebody you've got clinical depression, you're going to be clinically depressed.
Exactly.
You know? So, and that's the same that we find with people living with dementia. Alzheimer's disease and other dementia, and cancer, and anything else that we're trying to work with people with.
It seems like every time they write an article about dementia in the paper or Alzheimer's, they say they're suffering. It's a very key word that's always used. The poor woman suffering with dementia. No, it's about living with and hopefully living well with dementia, like diabetes or whatever else. So, and wandering. Oh, they're going to wander, and we still have all these lockdown units, and even at Highgate, we got to lock them in. But they, as Dr. Dan likes to say, they're walking with purpose. They know where they want to go. They're not going to walk across the street and kill themselves.
Well, and kind of what you said earlier, you had mentioned about the buildup of the plaque. Actually, there's been studies that half the people who have been diagnosed with Alzheimer's don't have the plaque. So
Yeah.
there's really no true association. At first it was, but now they're learning that just because you have plaque doesn't mean you'll have dementia or Alzheimer's.
Our problem here in America is that everything has to be treated by pharmacological intervention. Everything. You know, I'm astounded when I first came to America, being here for 2.5 years, astounded by the commercials on TV that spend about 3 seconds telling you what this medication is for, and then 3 minutes telling you about the side effects. And then the next commercial that comes on is an attorney telling you that if you've taken this medication, you call and we'll sue them. And the acetylcholinesterase inhibitors that we've got to treat dementia, specifically Alzheimer's, because they're only licensed for Alzheimer's disease, Aricept and epazil ribostigmine. The pharmaceutical
again, I'm taking notes.
the pharmaceutical companies have people believe, including clinicians, that these drugs will work for maybe 2 years plus. But they don't. The evidence, all the research that has been done indicates that they can work for some people for approximately 3 months. And then they stop. They're just inactive then. And as Kathleen said, Gandhi's work at Mount Sinai has demonstrated that rather than the neuritic plaques and tangles being the cause of Alzheimer's disease, they're actually the defence. And it's more about it's a free-floating ligament in the brain that is the cause of the disease. So the acetylcholinesterase inhibitors are wiping out the army rather than helping, which is probably explains why they only work for a very short space of time. Sorry, I keep hijacking this.
Yeah.
Go ahead. You take a couple questions.
I've had quite a few instances of people I know who've been diagnosed dementia. Almost everyone, my wife spent a lot of time in those group homes. Almost everybody in there was on antipsychotic medications. They were sitting like zombies.
Yeah.
And every time, her mother for one, her aunt for another, every time they start acting up, they want to give more medications, and they had ITUs, just like you said.
Right.
So,
Yep.
I mean, it's just the doctors don't look at it.
Right.
Just write the script.
We've got a different kind of training. That's here, the training is totally different than the UK. You know, over in England, your first month as a medical student, you spend working on the wards as a care assistant. You're making beds, you're changing patients, you're learning the fundamental principles of connecting with a human being. The doctors here have said to me that their training, I don't know if there's any medics in the room, medical training is totally different and more based on pharmacology. It's like, okay, what is wrong with you? This is the right drug for you.
We're very solution oriented.
Yeah. And as Kathleen said, the NHS system in England teaches us to, now anyway, is kind of think outside the box, and IBS, hypnotherapy. You know, Manchester General Hospital is the first hospital in the UK to open a specific unit to treat IBS with hypnotherapy.
And Kathleen referred to that. Do you have to have certain certification to do that? Do you have to have certain certification to take care of the idea to get
You go through the training program to become a clinical hypnotherapist, absolutely. Yeah. With depression, you know, our first line treatment for depression is a course of cognitive behaviour therapy and a prescription, some vouchers to go to the gym. Not an antidepressant.
So anyway, getting back to the study, by allowing individuals to relax and reduce rumination through hypnosis, resources are freed, allowing for improved functioning, and this appears to act to maintain itself, or individuals who have learned self-hypnosis, relaxation, and they believe that the data supported the value of a person-centered approach to dementia care. So I'd like to talk a little bit about the importance of working with dementia. In the U.S., the Alzheimer's Association says there's at least 5.4 million people that are living with Alzheimer's disease. And there's probably, could be 3 times that amount. Many cases go undiagnosed. People don't go to the doctor. They maybe oftentimes they're in denial or don't want to know. Every 67 seconds, someone in the U.S. develops Alzheimer's disease. And there are many other types of dementias, and as you said, there's over 100 types. So Alzheimer's is generally it's considered number 1. Then there's vascular dementia, which is a lifestyle disease, TIAs, vascular caused. And third generally is Lewy body dementia, which is caused by the Lewy bodies in the brain. And they're saying that apparently Robin Williams had Lewy body dementia. No, that could be a different, I don't know which one. So there's different effects because Lewy body can cause hallucinations. There's some types of dementia that cause a loss of inhibitions, and so that's why we teach it, because there's things to know about different types and how they affect people. It's not just old people. Niemann-Pick's type C is where about 1 in 150,000 children are born with Niemann-Pick's type C. They have a shorter lifespan. They develop dementia, say as a teenager, symptoms. So they're out there as well. And people that generally have, people worry about it being genetic. Usually that occurs earlier. They start having symptoms, say, in their 40s or so, when it's a genetic issue of Alzheimer's. So I mentioned the 3 most common types. Wait a minute. Codicil. That's one of my most interesting ones to recite. I don't know if you know Codicil.
Oh, you cheated. You can't bring it up.
Cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy.
Is this going to be on the test?
Yes. Can you say that 3 times? So that's a type of dementia. There's Kuru. There was one called Kuru. Kuru were people on an island where I guess somebody was infected and they were drinking the brain of the relative who died, and then they all got infected. So, yeah. And 2013, the Alzheimer's Association says 15.5 million family caregivers provided an estimated 17.7 billion hours of care. Think about how stressed out all those family members are and how they need our help and understanding with what's going on in their life. And I can attest to that. It's very stressful. Watching your parent, for example, that knew everything and now they, aren't functioning very well. It's hard to believe. The stress alone can be overwhelming, and we know how that affects the body as well.
Question. So do you tell them, no, you're not saying this right, or no, that's not, how do you dialogue that?
With person
Somebody
with
who did know things and now they don't, or they take something, excuse me, that's the opposite. They call you Sarah, and you say, my name is not Sarah, and they insisted things that they contradict you. Do you correct them, and if so, how?
Generally, no, because we like to enter their reality. You can explain that better, but
Yeah, it's about validating their beliefs and experiences at that moment in time. So if it's 1972,
Right.
then it's 1972.
Exactly.
And if I'm Sarah, then I'm Sarah. Yeah. What we do try to do with people who have got immediate memory loss and who can't remember my name, if you use something called spaced retrieval, which is a technique developed by Dr. Cameron Camp in America as part of the Montessori type principle, you get the person to remember your name for 12 minutes, or whatever it is you want them to remember, then it's lodged in the long term, so they will retain that information after 12 minutes. But it's all about validating people's beliefs and never correcting and that kind of stuff.
Yeah, I believe that. And working with seniors and working in a senior home and doing a lot of volunteer work with them, I would say to a senior, working one-on-one with them, that I would say to them, you know, how do you like to remember? What makes you happy? You know, what's a happiness for you? Tell me about a happy time. And music.
Music is the most amazing
Music was
vehicle.
wonderful. If you played old music for them, they could go back. Maybe they couldn't remember here, but they could remember there. And they would pull out something. It calmed them. It made them happy. It gave them peace. And it gave them a comfort, and it reassured something inside of them.
MARTIS, he developed MARTIS therapy, which stands for Music and Reminiscence Therapy Incorporating Storytelling.
These acronyms, man. I'm not going to nail this. That's so hard.
It'll help you focus, don't it? I think the really important thing is dementia robs you of your personhood. And every single person in this room is known by a role. Mum, dad, grandma, husband, wife, lover. That one weird kid. That one weird guy with the purple hair. And doctor, nurse, social worker, whatever we are. We have this role that we live through our lives with. Dementia takes it away from you, or tries to. And so the people that are caring for you on the whole, professional carers, help take that away from you by de-skilling you even more and more. So examples of people I've worked with in the past is like a retired GP who had dementia. He was living in a nursing home, and he kept going into people's bedrooms and touching people. Okay? Touching. And this was obviously a bit of a problem, a bit of an issue. So what we did was we got a little table and set it up for him with some very old prescription pads and a stethoscope and stuff. And he sat there day in, day out, writing, and got some old medical notes and stuff, just writing prescriptions. And he got his identity back. He was once again Dr. Frank, you know, he was no longer this guy with no purpose. This guy with no purpose. And I think that's one of the key things to supporting people to live well with dementia, is to ensure that they still have a purpose and a role in life. So giving people back a role is so key to the quality of life.
Okay. My screen looks a little different now. I don't know why. So understanding the more common types of dementia and how they impact the individual is an important thing to know. Do you understand what they're going through? Again, it's not just memory loss. It affects them in so many other ways. Do you understand what their family is experiencing? Know the various ways in which dementia impacts the person and their perception. When we teach the class, we have something that's put around the face, and people are amazed at how little they can see what's going on, because it's kind of generally how an older person, this is through research, perceives the world. It can be difficult to just look around and walk around. And on top of that, you can add on macular degeneration, cataracts, other issues. Also, how do you properly assess them, where they're at, their level of cognitive decline, where they are in the process of the disease, and how to work with them, the things that can present during sessions, and how to most effectively work with them based on their cognitive abilities or issues. As I was saying. So we know that hypnosis improves quality of life for dementia clients. It's important to be able to emphasize and effectively work with them to achieve positive results for the client and their families. I always like to think if a person has cancer, you probably wouldn't want to go to a pediatrician. This is a picture of Ole Olson. I don't know how well you can see it. He had tears in his eyes. He's living with Alzheimer's disease, and we had him come and speak at our International Dementia Conference that we had in November of 2013. And he just talked about, he and his wife spoke about the challenges that they live with Alzheimer. They call him their permanent unwanted guest. So that's what they call them, Alzheimer. So you can really make a difference helping these people through this work. And we are dementiatherapyspecialists.com. I brought with us today, I have 3 of our distance learning courses. Our distance learning course contains, for those who may be interested, a CD with our workbook, assessment forms, a copy of the study from Alzheimer's Care Today. There's 5 DVDs. One of them contains a session from one of the actual sessions from the hypnosis study with an interesting patient who couldn't remember Dr. Dan's name at first and then was showing up the door going, "Hi, Dr. Dan, you're here." So it was interesting to hear about the changes that he experienced. And then there's 4 DVDs that contain an actual workshop that we did a little while ago, I guess it was. But anyway, anything else I should mention? Our course contains a 1-year, what we call DTS membership, which has, you actually are put on our website, on our Find a Therapist page. We have a couple of websites, actually. When you're finished with the course, you have a session with Dr. Dan over what you learned, any questions, and also for the next year, you can pick his brain whenever you need to. You can call him up and say, "I'm trying to work with this client and I'm having these issues, and what do you suggest?" So that's also another good thing to learn how to work with specific issues. So, if you're interested.
I guess nobody's going to ask. Somebody might ask the question, but I'll be. Why does hypnotherapy work?
That's what I was about to ask.
I knew it. I knew.
I was focused on the question.
Yeah. And there are 2 theories. I have a clinical theory, and Duff has his psychological theory, which Kathleen did allude to, about when I've got dementia and I'm beginning to lose the ability to focus and concentrate and really trying to hold on to something, I'm worrying all the time that I'm going to forget this and I'm forgetting that and I can't remember, and the fear and the anxiety builds up and you're screwed, basically. So taking somebody into a deep-seated hypnotic state obviously frees all that up, and you're not worrying while you're in that state, and you're able to access the subconscious mind to make some suggestions and stuff, which you can't do with an antipsychotic drug. The second theory, which is one of mine that I'm kind of trying to work on further, is that acetylcholine is the chemical that is deficient in the brains of people with Alzheimer's disease. It's one of the main chemicals that's deficient that helps with memory. When you go to sleep at night time and you hit REM sleep, your brain gets a massive shot of acetylcholine. People with dementia, and certainly with Alzheimer's disease, when their kind of reticular activating system is dysfunctional, their sleep pattern is completely screwed, they're not sleeping as we would like people to sleep. Yeah? So the brain is probably not getting that acetylcholine that it requires. So one of my things is maybe when we are getting people into that state of REM sleep that maybe they're not achieving, or they may be achieving intermittently, then they're getting their acetylcholine shot. And it could explain why we had such good results longitudinal. The longitudinal study, 12 months post-treatment, because they were taught self-hypnosis. The team were taught how to use relaxation techniques with the guys. So if that was continued over that period of time, maybe they were still getting their acetylcholine release that they're not getting when they're trying to sleep and don't actually get to REM sleep. So that's the 2 theories. The acetylcholine one is one at the moment that we can only test via lumbar puncture, which we can't be doing that when people are in hypnosis because they wouldn't like it. But that's something that I would like to explore further to see, whether or not there is changes in the acetylcholine. And there's a guy over in Sheffield University who's working with MRI scans to try and work out chemicals and acetylcholines and things without having to be so invasive. So hopefully, at some point that will come to fruition and we'll be able to find out one way or another.
So are you saying that our body stores the acetylcholine and then it's being released when they're in this state of relaxation?
It's a possibility that it is still, it's just not being produced because you're not in the state where you need to be to produce it.
So what's the,
But I know, in the nutrition field, I've got people that come in and they've been saying, you've got this gene for dementia. And they want them to take choline. And you can take it as a supplement, you can get it in different forms and so forth. But so, this is what I'm just trying to understand that connection there.
I'm trying to understand it too.
All right. So you're not actually giving them, like lecithin or something that's really high in the process of serving them inositol and things like that. Other foods, you're just,
One of the foodstuffs that we do recommend for people now that come into our clinic in Prescott is coconut oil.
Yeah.
We push coconut oil. There's an ongoing study at the moment in Florida, University of Florida, looking at the benefits of coconut oil for people with Alzheimer's disease. Waiting for those results. I thought they would have come out by now, but they're not here yet. So that's going to be interesting, the coconut oil and the improvement in cognition that we've seen with people that come in to see us, that we use coconut oil with, as well as using hypnosis.
So with the acetylcholine that you're talking about, can you take that one step further with people who have major sleep disturbances? You think that's also valid?
So possibly, I don't know, I'm not a sleep specialist, but it's...
But isn't a lack of sleep could be a part of what causes Alzheimer's disease?
One of the pieces of research that has been published lately does demonstrate that sleep does have a possible impact on developing dementia. And I just think back to Margaret Thatcher, who some people you've probably all heard of Margaret Thatcher. Heroin. She obviously went on to develop Alzheimer's disease and vascular dementia. And,
Mixed dementia.
Yeah, mixed dementia, which is really, really common. Mixed dementia is so common. It's very unusual just to have Alzheimer's disease. This is another thing about dementia. All this stuff you can learn on a course, but it's really interesting stuff. But she notoriously slept for about 4 or 5 hours a night, and maybe that.
Another connection with endocrine and adrenals.
What?
Adrenal function. Actually, adrenal burnout, because of the fact that it does affect cognition, and long-term adrenal burnout can actually affect. And the whole cycle of an adrenal spike, fight or flight, has a direct connection to acetylcholine release.
Right.
So if you go back, track that way, you could probably do in the study, instead of necessarily going to that level, checking cortisol levels, and checking cortisol levels is through saliva, so there's no invasion.
Yeah, that's good. I shall look at that. Yeah, thank you.
Any other questions?
I have a question. I've dealt with a lot of Alzheimer's people, not because I wanted to, it's because they didn't allow me. But I've had several that were trained to kill, as in police officers, people that were in the military. They're good guys, supposedly what you would call good guys, but they were trained to kill. And if they believe they're being threatened, they hit nurses and things like that. I think I have another one coming up that I'm going to deal with. Would it be safe for a person to be around a person like that?
Yeah, I think,
How do you deal with them not?
Again, what we have to think about is, when we say acting out, we have to look at why that is actually happening.
Protecting themselves.
What is happening? I mean, if I was to take you now and put you in a locked facility with people with uniforms on and pushing drug trolleys around and things,
People you don't
What
know.
would you do?
Yeah, and they don't like to be restrained.
What would you do?
What would I do? Under what conditions?
Well, if I just took you out, and said, right, you are now living in my lockdown facility,
And you
you
were,
are a patient to me now,
I was convinced that it was
and I'm not going to let you out.
I'd be better served.
I'd be plotting a way to get out.
Yeah. You won't be happy, would you?
No,
No.
I would do whatever I have to get out.
And
And
this
if
is, yeah,
Knew strategic places to attack somebody, if I saw that I could get out the door, I'd do that.
and this is the thing, this is what we do. You know, we take people from a natural environment and shove them in an unnatural environment.
People that are in control.
Yeah, and
Over to
it's
people
like,
they don't
okay,
even know.
pick you up now, take you from this environment and put you in a nursing home type environment. It's unfamiliar. You know, we've lived our life off something called an ecological inventory. Inventory. Which is
Speaking
basically,
American.
which is basically your environmental cues. And we've got train stations, signs, post boxes, churches, schools, pubs, all these things. Suddenly you're taken away from that environment and you have nothing to give you a cue or a clue as to where you are and what you're doing. And then you've got these people in uniforms. Well, you know, what's that all about? You know, we did something in England where we took the night staff, the night nurses, out of their uniforms and put them in pyjamas.
Yeah.
And when people woke up at night time and saw these people in pyjamas, it was normal, it was natural. Whereas the other group were waking up and the nurses were there in uniform, and this was not normal, this was freaking me out, this is making me anxious and scared and frightened, so I may then act out. So a lot of the behaviours that we see, the behaviours that are challenging, are there because we put them there, we create them. It's our fault. And yet it's always said, oh, he's got dementia, so you know, he's behaving like that. No. Why is he behaving like that?
And we do this thing sometimes called the Hermeseals, which is Alzheimer's spelled differently. And the chief Hermeseel takes you away to the Hermeseel facility, and it goes through this whole explanation. And then you realize at the end of the story what just happened and what that was like, what that feels like when that happens.
But with that control thing, that's what happens. You know, with dementia, you begin to lose control of all kinds of things that you've controlled all your life. So you try to control things in any way you possibly can. And you behave in any way, you use whatever resource you've got, cognitive resources, to survive and to try and make sense of the world, kind of thing. So what we interpret as being, yeah, that is a behaviour that's challenging and I need to give you some medication or sedate you or stop you from hurting yourself and other people, is not the right way to think. You need to reverse it.
It's about asking different questions.
Absolutely.
Because, especially with the point that you had brought up, the question goes back to what you were talking about, body-mind, is why did the subconscious even create that?
Mm-hmm.
So why are you creating it? There's something that I have done in my past
Right.
that I may not be comfortable with, and I cannot deal with it today. I'm going to create, in order to function in my reality, I'm going to create a change today so that I can cope.
Yep.
And so now the answer goes even beyond. It goes to, how did I create this? And the answer is to change the way I cope with what I may have done and what I might want to forget.
Do you have a photo of the woman with the Elvis somewhere? There was a story, for example, a woman in one of the care homes that Dr. Dan was at, where she was waking up during the night pounding on the walls. You know, normally it's like, oh, let's give her another antipsychotic. And they looked at her history, and years ago she'd lost a baby. And they have these kind of realistic, there's doll therapy now, where took this doll and put it in a crib in her room. So she wakes up at night, sees the doll, she's happy, goes back to sleep, or takes it back to bed with her. No need for medication. You know, it's a matter of working with her reality. So I know there was a pub that Dr. Dan worked on in Northern Ireland that had
A pub that you worked on,
excuse me. I meant to say, sorry, I had that backwards. A care home with a pub is what I meant to say, and a nursery, and a chip shop, fish and chip shop, so they could drop the doll off at the nursery go have a pint at the pub, this is in the nursing home, and go to the chip shop and have their traditional fish and chips. And maybe remember to pick up the doll afterwards before they go back to their room.
That's it, I'm sending my grandma.
So, well,
See,
Holland,
better in the Netherlands.
yeah, I'm going to say in the Netherlands. Anyway, so just a lot of interesting stories on how to really improve quality of life.
But with hypnosis, using hypnotherapy and hypnopsychotherapy, if people use hypnopsychotherapy as well, it really is about understanding the disease process and what kind of dementia the person has and how it's affecting them. Because we have to do things differently working with people with dementia. It takes much longer to develop a therapeutic alliance. It takes much longer to teach an induction and work through that process. So
That's why we didn't want to just do a quick demo, because it's a little more complicated.
So did you do weekly for 9 months?
that's right.
And since you were the only operator, so you're the person, how reproducible would it be if somebody else were to do this? Because it sounds like you're using scripts, but if you're doing hypnopsychotherapy, that's going to vary in the techniques. So I'm just thinking you might be a particularly talented person with a lot of experience, and you take somebody who doesn't have that much experience, would they get the same result?
Yeah, I've been trying to find somebody to replicate it for a long time. Nobody will take it on.
No.
Nobody wants to do it. There was some possibility of us working with Margaret T. Morris down in Prescott. But my reservation is I don't want to do it. I want somebody else to do it.
Right.
Yeah. Otherwise, it devalues
Right.
the work if I do it, and the results are good again. It's like.
So the training that you're providing, I assume it's something you could purchase, the DVDs, or maybe do some personalized training live. How do you do that?
We do some Skype
Yeah.
stuff.
That's what I said. We
Skype
have. I
things.
brought a few of the
So
distance
for
learning
somebody who would be
packages.
interested in doing this kind of work, you would pretty much lay it out so you get, because you're the expert, world expert.
If there was enough people here, if there was enough people interested in doing the workshop, I would come to Phoenix and do a 2-day workshop. Do because I prefer. I'm old school. I
Good.
prefer people in the room, and I prefer to work with people and stuff. So, but our secondary thing is I can't go to Hong Kong. I can't go to Italy. I can't
No.
to South Africa. So we work via Skype with
Right.
those guys.
Do you do one-on-one
Yeah.
Skype, or do you try and have a group?
No, it's a one-on-one.
It's a one-on-one.
But that's for the follow-up on
That's
distance
all, yeah.
learning.
Yeah.
There's only one person in Phoenix that took it, and the distance learning, and I don't even know if she's practicing at all right now. So,
Is she on the website?
yeah.
Sue?
Mhm.
Sue Henry?
Do you see any individual clients yourself up in Prescott? So are they local residents, or they drive from?
There's people that come from Sedona, there's people that come from Kingdom, they come from
And do you do Skype sessions with people?
Well, Kathleen actually worked with a guy in Kentucky.
For several months, I worked with somebody in
24 weeks.
Kentucky, and that was interesting.
And another interesting thing is that it doesn't matter where that person is in their journey through dementia. So it doesn't matter where they are in their dementing process. I have found post-study. I use global deterioration scale to assess
What
where they
about
are.
for
1 to
nonverbal?
7.
You work with nonverbal?
Yeah, absolutely. Yeah. What?
Just think about that death. That was something.
See, when I went to study hypnosis and hypnopsychotherapy because we were looking at the time in the UK of what can we use other than pharmacology. And so I was looking for things, and I was the senior dementia doc at the time for the UK. So I thought, well, let me have a look around. And I looked at CBT and NLP and did all these kind of things, and then tried hypno. And the first question I asked the tutor, because this was a 4-year course of hypnosis, the first question I asked John Bealby, he was called, was, can we use this with people with dementia? And he was like, fear, just, you could see the fear. And of course it was, well, I don't know. And then I said, could we use it with deaf people as well? And same thing. So a year or so after I'd finished my training and I ran the first clinical course, myself and Duff ran the first clinical course in London, he came on it and studied it. And I was using a nursing home at the time because I was, responsible for this big nursing home in London. So we used that as a place so that the students could go and work with clients with dementia in the wards, in the various wards. And I chose a very, very deaf man for John Bilby to work with. And I was walking through, just trying to listen at the door to make sure everything's okay. And I was walking down the corridor and I could hear him shouting, "You're relaxing now!" Anyway, afterwards he told me it worked. So yeah, I will work with anybody. I will attempt to work with anybody and never write anybody off. And the gentleman that Kathleen works with over in Kentucky was pretty severe. His journey, he was quite away, with his journey of dementia. And it took quite a while, didn't it, for you to get him going. It took quite a lot of sessions to actually get that therapeutic relationship and stuff. And Kathy came up with some really, really good ways of working with him. And it was interesting to see. And then he started looking forward to it. He was nagging his wife, when am I seeing Kathy? When am I seeing Kathy? So he was always ready, for the Skype. He was always sat in front of it, ready, waiting. So, and I find that you just have to be more adaptable and a lot more. So the kind of work that you did with you there would have taken much longer, to actually achieve. You can achieve results, good positive outcomes, but it takes time. So you have to plan your time for that. When you're working with guys with dementia, it's about allowing yourself maybe a 2-hour time period between sessions rather than an hour or whatever it normally is. Lots of stuff. It's very interesting and it's fantastic, and I love to see people with dementia. I'm just like him. My saying is, if I can turn a frown into a smile at the end of the day, job done. That's worth its weight in gold.
Well, I want to thank the Nightingales for coming and giving an amazing presentation. Thank you both. Any other questions before we give them a break? Do you have any other questions? Thank you so much.